Hello, I'm Jared Weiss. I'm a professor of medicine at UNC Lineberger's Comprehensive Cancer Center, and it's a privilege today to be joined by Dr. Sid Sheth, an expert oncologist in head and neck cancer, also at UNC Lineberger Comprehensive Cancer Center. Welcome, Sid.
Thanks so much for having me, Jared.
So why don't we start off by making sure we all know what we're talking about. Most head and neck cancer fortunately presents in a curable stage. And so in contrast to some other cancers, we have the pleasure of treating most people with a goal of cure. But in a very basic way, Sid, do you want to go over for us how we do that, the basic modalities?
Yeah, absolutely. And I think as Dr. Weiss mentioned, 90% of our patients will present at a stage where we can use curative modalities. And so this involves 3 primary treatments. 1 is radiation therapy, 2 is surgery, and 3 is systemic therapy, usually with chemotherapy. And so depending on the stage of presentation, we might use one of these modalities, either surgery or radiation therapy. And in other situations where there's more advanced disease, we might use a combination. So surgery followed by radiation therapy, or chemotherapy and radiation given together.
So I think a key thing that we face in our practice is the decision between surgery or radiation as the definitive modality, probably one of the most common dilemmas we face. In general, not a survival difference between the modalities. Our more advanced patients who are going to need more than one modality can get surgery, and then we look at the pathology report to decide what, if anything, we need to do next. Or we use chemo and radiation up front, and in the case that we don't cure people, surgical salvage can be used, albeit those surgeries are much larger. Any particular situations where you might favor one over the other?
Yeah, I think so. Data and historically for oral cavity cancers, often this is primarily driven by surgery up front. And there is a movement, but not all places do it, where you have oropharyngeal cancers, so in your back of your tongue or your tonsils, where there's a greater movement towards using chemotherapy and radiation together. And then finally, in your voice box or your larynx, there's criteria for both, but it's typically a surgically driven area for where your cancer is. But there are some indications, particularly if you can save your voice functioning, where you would do chemotherapy and radiation together.
So you and I share in common that we're clinical oncologists, meaning that we're giving chemotherapy every day. And I think if I look at both of our investigative careers as a theme, I think there's a drive to bury chemotherapy, right? So on the opposite, the two things that we do at work are sort of a little bit at odds with each other. Cisplatin to me is a beloved drug because it cures people, buys decades of quality life. When you add cisplatin chemotherapy to radiation, you improve the cure rate. Cisplatin in parallel, very hated drug because of its extraordinary toxicity profile. Hearing loss, ringing in the ears, nausea, blood count suppression, damaging the long nerves that go to the tips of fingers and toes, kidney damage. I'm probably still missing a lot, but obviously a lot of problems. What's your perspective on the use of alternative agents that might be a little gentler?
Yeah, I think, you could take any head and neck cancer specialist, and most or the vast majority would be happy if cisplatin completely went away. There's been such a large effort over the past couple of decades to replace cisplatin, and using agents such as cetuximab, which is a targeted therapy targeting a pathway called EGFR. We've looked at immunotherapy, which I'm sure we'll talk about in more detail. But yes, even in 2021, after 50 years of using cisplatin, it still remains to be king for the vast majority of patients in the curative setting.
So we have a randomized study showing that cetuximab and radiation together were better than radiation alone, but some new data shedding light on the difference between these agents.
Yeah, absolutely. So the first study that came out was the Gore-Tex Reach study. And so this was a little bit involving both cetuximab and cisplatin combined with radiation. But what was twist or novel with this study was the addition of immunotherapy. And in this study used an agent called avelumab, which was combined with radiation plus cetuximab. And that was compared to cisplatin and radiation therapy. And so the hypothesis was that could we use treatments that might be gentler than cisplatin and still have good safety data and efficacy data? And, unfortunately, what we were seeing is that in this large phase 3 study, there was not an improvement adding immunotherapy or the avelumab to cetuximab. And in fact, the survival outcomes, which was 1-year PFS, was actually higher in the cisplatin population.
Yeah, I was somewhat disappointed by this data, given how wonderful immunotherapy has been in our incurable patients, giving a nice improvement in survival, and in some patients even a decreased toxicity profile when we're able to give immunotherapy alone. And we get a cure rate in previously incurable patients with immunotherapy, not as high as any of us would like, but it really led credence to the idea that it really should have been better, right? And that's clearly just not the case. We've had other studies showing the failure of combining immunotherapy at the same time as radiation therapy. We had another study called PembrRad that looked at pembrolizumab in radiotherapy versus cetuximab in radiotherapy. And while the pembro was no worse, because remember cetuximab is active, it was really a bit of a surprise that it wasn't better. And then on the other side, there have been efforts to add radiation to immunotherapy to potentiate it, that at least in head and neck cancer have been pretty unimpressive. A few years ago, I want to say, it was pre-pandemic, so I know it couldn't have been in the last 2 years. We had a study looking at Nivo with stereotactic radiotherapy that really did no better than nivolumab, another PD-1 inhibitor alone. So, that's been a disappointment, right? We had all kinds of scientific reasons and prior clinical data reasons to think that this would be better. So are we done with adding immunotherapy to attempts at cure, or are there other good ideas out there?
I think we'd be bad oncologists if we were said this was the end of immunotherapy. And I'll echo your sentiment. I am so disappointed that some of these trials, including the Javelin study, and I'll just mention that this is added immunotherapy with cisplatin and radiation therapy, was also not superior to cisplatin and radiation therapy. So we've demonstrated again and again that we just cannot move cisplatin off the throne. And so to answer your question, I think there are definitely going to be other opportunities to incorporate immunotherapy into the curative setting. And so one area of interest, and definitely ours, is trying to bring immunotherapy at the very beginning, either prior to surgery or prior to chemoradiation therapy. And so I see that as a great opportunity to potentially lead to immunotherapy having a role in this setting.
Yeah, I very much agree. I love the approach of doing things up front, in part because what's working. We have a bit of a culture in head and neck cancer that any systemic therapy to be used has to be used concurrently or in advance, not to use chemo out back, as is done in most other human cancers. And I would just point out that in lung cancer, after chemorads, immunotherapy creates a rather dramatic improvement in survival. And there are efforts looking at doing that in head and neck as well. And I'm kind of grateful to our colleagues that willing to break that culture and try that again.
Yeah, absolutely. And a less common cancer, for at least what we see in the US, is nasopharyngeal squamous cell carcinoma. And they just, this disease group just came out with a very positive study showing that a chemotherapy called Xeloda was effective versus placebo in the maintenance or after definitive treatment. So yes, there certainly will be a role, and again, looking forward to seeing more data that comes out over the next few years.
So just to finish off the pessimistic trail here, to come back to cetuximab a little bit, we did have data on cisplatin versus cetuximab. And we now have data, I'm not going to walk through it, but I'll say that both particularly in HPV positive cancer, but an HPV negative, well, it just doesn't look as active. So it's still an FDA approved option in a patient who's just not a cisplatin candidate. It certainly can be considered over radiotherapy alone, but the enthusiasm for it, I think, appropriately continues to dwindle.
100% agree.
It's just not as active with radiotherapy as we had wanted it to be. And we wanted it to be. It's a whole lot less toxic, but of course, we have to look at reality as it is, not as we wanted. Another failed effort in this arena was TryHard. I don't know if they doomed themselves with the name, but lapatinib was an interest of mine back in the day. There was some preclinical data. If drugs like cetuximab action EGFR, drugs like lapatinib action more its partner in crime, HER2, better known in the breast cancer world. And we've really had a series of negative trials with lapatinib. The most recent was trying to add it to chemotherapy and radiation. To me, one of the lessons here isn't so much about lapatinib, but about data interpretation. In the investment world, in the academic investigative world, and certainly in the patient advocacy world, I hope I'm not offending anyone, there's a struggle because we're so thirsty for advances. There's often an assumption that what happens in phase 1 or phase 2, particularly if the phase 2 is randomized, is definitely going to happen in phase 3. And to sort of count our chickens before they've hatched, we had a really nice randomized phase 2 positive trial here that turned negative in phase 3. And there have been a handful of other examples in oncology recently. And just to me, maybe not so important about lapatinib. I buried it years ago already. But just maybe a reminder to all of us to not count our chickens before we hatch and to have equipoise and to really do our homework properly.
Yeah, I couldn't agree with that more. And I think you said it perfectly, but we take really exciting agents that are studied in cell lines and mice, and we bring it into early human studies and get more exciting data. And then we finally take it to a phase 2 study and a randomized phase 3 study. And I think what the TryHard study demonstrated, and which many others that have preceded have as well, is that the bar to get a new agent to be approved, particularly in head and neck cancer, is tough. And so we are going to just continue fighting on. But I think lapatinib's story, at least in head and neck cancers, is maybe coming to an end. Would you agree with that, Jared?
Yeah, sadly so. Lapatinib holds a special place in my heart. It was the first trial I ever wrote, was a lapatinib trial. And, one of my first on faculty was a lapatinib trial. But, the data that led to those trials was really present at a very different time. I think the data has evolved in a way that convinces me that we were just wrong. We had hope for it. And looking through what sometimes we call the retrospectoscope, looking back with 20/20 hindsight, it was just wrong. It's not an active drug in head and neck cancer. There are much better ideas out there.
Great.